At this year's ASH meeting in Atlanta, we are presenting new data on patients that are newly diagnosed with multiple myeloma using Carfilzomib at a higher dose than we have previously used. This is a phase 1/2 trial. We use 45 milligrams per meter square and 56 milligrams per meter square as the two dose cohorts. 56 milligrams per meter square turned out to be the safe dose that we could use for the expansion phase in the phase 2 component of the study. Here at ASH we are reporting on the use of this, and as I just pointed out, it is a safe dose, and give it twice a week works very well from a safety standpoint. The primary endpoint of this study is to look for minimal residual disease. At this point, MRD is typically included as a secondary endpoint in clinical trials, but in this phase 1/2 trial, MRD is the primary endpoint. The study is currently ongoing, so it's not finalized. We just completed and reopened, we completed the first part and reopened the second part of the study. So that indicates that the study is promising, otherwise we would not open the second part. I would think that the study will be completed probably around the summer of 2018, but the preliminary results are very exciting, and they indicate that you can obtain very deep levels of response with sequencing-based MRD in high proportions of patients. Another feature of the study is also to use MRD to guide the therapy. That's also something that has not been done in other studies. So patients who reach MRD negativity earlier in the study, they will get fewer cycles, and patients who take a little bit longer to achieve MRD negativity, they get a few extra cycles, and that's regulated by the protocol. No patients go beyond 12 cycles, so it's not an attempt to give unlimited cycles, so there is a cap for that. I do think that we are going to see more studies in the future where MRD will guide treatment, and I could see that MRD could guide, for example, the use of transplantation. In our study, we use MRD to guide a number of cycles. I could see that MRD could guide when to go to maintenance. And for patients who are MRD negative and turn MRD positive, if that were to happen, I could see that could also guide to restart combination therapy, for example, in patients on maintenance. So there are a lot of novel components in this study, and it will be very exciting to see when the study is completed, probably mid-2018.